my name is Gaumont. I'll be one of the student physical therapists working with Sergeant Major today. So Sergeant Major is a 50-year-old male reporting to the clinic with low back pain that he describes as central aching, burning, and bothersome. The pain is localized in his back and sometimes goes into his sacrum, but rarely ever goes into his lower extremities. The pain is interfering with his ability to score his usual near-perfect score on the APFT, which he takes pride in. The pain is aggravated when he goes for hard runs without at least a 20-minute warm-up, and activities such as the 340-pound deadlift and the sprint with two 40-pound kettlebells tends to cause him to be sore for multiple days afterwards. He has no remarkable medical history other than a below-knee amputation that experiences phantom limb pain, and he manages his low back pain with ibuprofen and water. He is physically active and works at the local gym and is coming to see us because he doesn't want to show weakness in front of his soldiers. So for questions that we'll be asking when the pain started and ask him to rate it on a scale from 1 to 10. We'll ask how the pain has progressed over time and if the pain tends to be worse on one side of the back compared to the other. We'll also ask what his usual fitness routine looks like and how it's changed due to the pain, and if there's any particular movements that make the pain worse. We'll also be asking when the last time he had an appointment for his prosthetic leg was. So for the systems review, for cardiopulmonary, he had a blood pressure of 110/72 milligrams of mercury, a heart rate of 68 beats per minute, and a respiratory rate of 15 breaths per minute, and an SpO2 of 98%. For integumentary, his integumentary system was intact. For musculoskeletal and the postural assessment, he had slight bilateral rounded shoulders and slight forward head posture. For neurological, he reports phantom limb pain in his left lower extremity. And for communication and cognition, he is ANO times 3. So for our first subjective test, we did a lower quarter screen. We observed his posture, gait, and functional movement patterns. For neurological screens, we looked at dermatomes for L1 to L5 and S1. And then for myotomes, we looked at L2 to L5 as well as S1 and S2. And then we did deep tendon reflexes on the patellar tendon and the Achilles tendon. Okay, I'm going to pass this off to my classmate, Lauren.
Hi, my name is Lauren. I'm a student physical therapist, and I'm here to talk a little bit about Sergeant Major. So getting right into his lumbar spine screen, we looked at his range of motion for flexion, extension, bilateral side bending, and bilateral rotation. The flexion, extension, and bilateral side bending were all limited and also caused pain, and the bilateral trunk rotation was not painful, but it was limited in its range of motion. And also looking at the hips, hip flexion, extension were also within normal limits of range of motion. Moving on to manual muscle testing for the hip, so flexion, extension, AB and AD duction, internal and external rotation, adduction, internal rotation, external rotation were all within normal limits, especially just keeping in mind he has that BKA, and hip flexion, extension, and abduction were all strong. They were either 4 or 4+ out of 5, but they were limited by pain as well. So moving along, we have the functional movement screen. Just had him go through a couple things like the deep squat, hurdle step, inline lunge, active straight leg raise, trunk stability, push-up, rotary stability, and shoulder mobilization. Moving through an objective test, we have the modified sit and reach test. So this is where he scored 9 centimeters. Ideally, we'd be looking for 12 to 14 centimeters. So we kind of worked that into one of his goals to improve by between 2 and 2.6 centimeters to show that it is a real improvement. And then moving on to today's treatment, we started with a warm-up on the treadmill. Did 4 exercises with him. So we did supine hip thrust with a 5-second hold, kettlebell chops, walking lunges with 1 kettlebell, and a modified deadlift, so we can get back to that. And then we concluded that treatment with ice on the low back.
Hey Sergeant Major, how you doing? My name is Jaydon. I'm going to be one of your student physical therapists working with you today. I believe before me you saw Dylan and Lauren, and after me you'll see our colleague Tyler. What I'm here to do today is to discuss any sort of imaging that we're going to be sending you out for. And we're going to be sending you out for an x-ray. The reason for this is because it's going to allow us to rule in or out any sort of involvement within your spine. And once we get that image back, we'll have a clearer picture, literally, of what to do going forward. Because the x-ray is going to allow us to identify any sort of narrowing of your disc spaces, end plate sclerosis, which just means any sort of hardening, osteophyte formation, and then gas within the joint space. And again, like I said, once we get this image and can read it and know what's going on, we can move forward with your plan of care.
Some people may ask us why we have chosen the specific objective test that we have picked for Sergeant Major. For the manual muscle test, it allows us to assess for weakness, pain, and determine if bilateral discrepancies are present. In the lower quarter screen, it allows us to assess for nerve damage of spinal roots affecting lower extremities, as well as posture and gait. And the lumbar spine screen allows us to assess for pain and functional limitation of movements and biomechanics, and then to make corrections as applicable. And then the functional movement screen allows us to screen for injury risk, asymmetry, and dysfunctional movement patterns. And then the modified sit and reach allows us to assess for flexibility of the low back and hamstring muscles. So after doing these on Sergeant Major, we found that on his lower quarter screen, there were no bilateral discrepancies on dermatomes, myotomes, or reflexes. His lumbar screen was limited in range of motion in all trunk motions and in hip extension and flexion due to pain in the lumbar spine. His manual muscle test was strong, but limited due to pain in flexion, extension, and abduction, all within the hip. His functional movement screen, anterior forward lean during all motions, and genu valgus during squat, tight hamstrings and quad, pain and weakness with rotary stability, and poor shoulder mobility due to hypertrophy. And his modified sit and reach was 20 centimeters with pain. So we see that there's some things going on, limited range of motion, along with that poor sit and reach test at 20 centimeters, which is below average, and with pain. So we definitely found things that can help us with our diagnosis. So we sent him to get an x-ray. We haven't gotten it back, but in the meantime, we're looking at 2 different x-rays that show what we may think it is. And with that, we have 2 x-rays, a frontal and sagittal view, because 2 photos equals 1 story. In the frontal, and the image that we have on the slides, it shows degenerative disc disease from L5 to S1, but it's not so clear because we're looking at it on that frontal view. And the view that we would want to see is mainly on that sagittal, because on the frontal, we don't get a great frame of that intervertebral disc. We mainly just see the vertebral body. So in the sagittal, we can clearly see degenerative disc disease between L4 and L5. So with Sergeant Major, we have determined that he is not a complex patient due to his history, examination, clinical presentation, and our clinical decision-making. So within the history, there is no significant limiting personal factors or comorbidities. On his examination, there's only one primary area of concern, which was his low back. His clinical presentation, patient's condition is stable and uncomplicated. And this is all due to his past history of being in the Army and enjoying exercise. And then our clinical decision-making is standardized patient assessment. So while we were writing our SOAP note, we put together some short-term goals. And with those, we have in 2 weeks, patient will experience decreased pain at night, allowing for comfortable rest, which will also improve his recovery. In 3 weeks, patient will display improved biomechanics, allowing for decreased soreness and pain after intense exercise, as well as any sort of functional movement, such as just bending over, picking something up, cleaning around the house, any sort of those chores that can put strain on the low back. And in 4 weeks, patient will deadlift 75% of max of training towards his AFT. While this is not functional, it pertains directly to his goals, which can increase his motivation to want to come and get better every day. Now I'm going to pass it on to Tyler.
Hello, my name is Tyler Lovedale, and I am a student physical therapist at UMass Lowell. And continuing with what Jaydon was saying, some long-term goals that we have planned for this patient is that at the end of 8 weeks, he will increase his modified sit and reach score by 2 centimeters to show a statistically significant change. And also, at the end of 12 weeks, he will be able to score a 450 on the Army fitness test with minimal pain after completion of all the events. We believe his suspected medical diagnosis is degenerative disc disease, as he is over 40 and his pain lingers with certain exercises but doesn't radiate below the gluteal cleft. For his physical therapy diagnosis, we would consider it impaired lumbar stability and function. We would consider his prognosis very good, as he has a long history of fitness and is very motivated and passionate about getting back to his prior function. The one thing that may limit his prognosis is his no pain, no gain mindset, which may lead to improper rest and recovery that is needed for him to get better. His plan of care will consist of 1-hour sessions 2 times a week for the next 12 weeks with soft tissue mobilization, modalities, specifically cold packs to help with his pain, and Therax specific to his Army fitness test, which include a 3-rep max deadlift, push-ups, planks, and a 2-mile run. Finally, we also gave him a few exercises that he could do at home, which include the double knee to chest stretch, supine pelvic tilts, windshield wipers, and bird dogs, which will all help with core stability, spinal mobility, and lower back health. Overall, we are very excited to be working with Sergeant Major and can't wait to see how much he progresses.